So today we'll be talking about front of neck axis. Okay, this is a short video of the famous Elaine Bromley case that happened in 2005. This patient came, this is a simulated version, and this patient came for uh, ENT surgery, endoscopic surgery, and landed up brain dead and died 13 days later. So today, front of neck axis, why I'm showing this video, you will come to know. Okay. So she was given propofol, induced. They tried to put an LMA. We finished SGD sessions last time and they couldn't. So the saturation started falling. There was tachycardia. She did bag mask. The saturation fell down to 46. Then they are hunting for instruments, devices to save the airway, oxygenate. There is trauma occurring. The ENT surgeon later on walks in. Okay. They tried intubation. Still the same person is doing. Okay. There's a lot of trauma. Meanwhile, there is hypoxia. And slowly bradycardia occurs. And then they decide to change hands. Okay. There is no pre-oxygenation, para-oxygenation. There is no instrumentation ready. They had a fiber optic, but they didn't think of. So everything. Today we are talking about front of neck axis, but it's a part of an airway rescue, algorithm. So all the devices are important, and front of neck axis, God forbid, if any one goes through it, it's the timing. Okay, front of neck axis is mainly when the saturations are good. You have to decide. So therefore, you should be prepared for anything. So being prepared for an emergency, what does it mean? Especially for an intubation, it equals to being prepared for any sort of emergency. Make a plan accordingly. Build a kit with the equipments you are comfortable with and be informed of its advantages and limitations. This is how, especially for a freelancer, you should have everything ready. And even when you're working in institutions, your cards, your emergency. So the FONA is a very important step. You begin to do FONA right from the beginning in the PAC itself. And for unanticipated, it's mostly for unanticipated. It comes as an emergency front of neck axis. So for that, your drawer D or plan D drawer has to be always and always ready, okay, in your difficult airway crash cut. So what is the definition? Any access to the airway from the front of the neck is a front of neck access. It can be either emergency or elective. Now, in the DAS, it is the plan D, that is emergency. It's for a difficult intubation, especially unanticipated. And even anticipated difficult airway, you have front of neck, you have fiber optic scope. For awake fiber optic scope is the gold standard for anticipated difficult airway. But anytime in this process, it can go from anticipated to unanticipated. So front of neck axis is very important to take the decision when everything is good. Okay, so not only organic or physical difficult airway, even when the patients suddenly, they can go into physiological difficult airway. There can be an arrest while you're intubating. You cannot intubate in seconds. So you must have an airway access, and front of neck access plays an important role to take a decision when the saturations are good. Okay, and you are in unanticipated, the plan D, that is unanticipated difficult airway, when you declare cannot intubate, cannot oxygenate, that is when your emergency front of neck access, that is scalpel cricothyroidotomy, that is plan D. So nowhere they are saying ki the saturation has to fall to declare the front of neck access or declare CICO situations. Okay. So this is very, very important. In a tracheal intubation for critically ill, in ICU also, they are asking, the plan D is front of neck access, emergency scalpel cricothyroidotomy. In obese patients where you have failed tracheal intubation, when you declare CICO, give 100% oxygen and go for front of neck access. So the main thing is difficult intubation, difficult tracheal intubation, difficult bag mask ventilation, and even the supraglottic airway device, when they fail, you declare CICO or plan D, that is FONA. Okay, that is front of neck access. It's now called as emergency airway access. Okay, now which is what is the limitations of your algorithms? Algorithms say ki you need to do 3 times, you have to attempt for intubation, 3 times you attempt for your supraglottic airway devices, then bag mask. No. In Vortex, it's a very novel idea of airway management where you have high acuity implementation design tool designed to support the uh, team function and decision making in airway crisis management, wherein you have to know the limitations of the algorithm. They have fixed a number of attempts, the fixed cognitive errors, so you can either use a bag mask or a supraglottic airway device or an intubation to maintain the green zone. The green zone has to be maintained always. Now, this is a funnel shaped uh, uh, tool or a tool for understanding this. How, like, this is a green zone, and that is the good oxygenated zone. And the blue zone, that is a hypoxic zone. You can see it goes on darkening and spiraling downwards. This is a dark hypoxic zone. That is when the patient, the saturation keeps falling. Okay. And at the tunnel, tip of the tunnel is a green zone. That is your FONA. So at any stage, you have to jump from the blue. When this is spiraling, you have to jump from the blue stage to the green zone. Okay. So need not have 3 attempts of intubation laryngoscopy, 3 attempts of SGD. No. The minute you decide that this patient cannot be handled by me, you have an complete right to jump to FONA at any stage and go into the green zone. Okay. Use anything, your edgins, your supraglottic airway, your bag mask, or your uh, endotracheal tube, and finally FONA to jump to the good saturation zone. So for emergency airway access in as according to plan D, you have to call for help initially, which in the initial video of Elaine Bromley, you saw that she kept on trying. So the minute you realize you are alone, and you're trying to intubate and it has not gone in the first go, you better call for help and up the oxygen. She has not given any oxygen pre-oxygenation, or while intubation also she has not given oxygenation anytime. So you have to remember that it's the hypoxia which kills, which causes brain damage, and hypercarpia, that is ventilation delay, will not cause any that much problem as much as the hypoxia. Okay. Hypoxia causes permanent brain damage. So you have to, at all the time when you're trying to oxygenate, you have to pre-oxygenate and para-oxygenate